Hello, ladies and gentlemen. Welcome to our ongoing series of lectures on anesthesiology. In this lecture, I'm going to spend some time talking about emergencies that occur in the operating room. This is a highly selective group of emergencies we're going to discuss, one of which is unique to anesthesia, but extremely rare. So this is the agenda for our talk. The first discussion is going to be on malignant hyperthermia. Then we're going to discuss cardiac arrest in several forms, including those forms that are treated through advanced cardiac life support programs, hyperkalemic arrest, which is not unique to anesthesia, but is certainly a problem in anesthesia, and arrhythmias. We'll then talk about massive hemorrhage, anaphylaxis, head injuries with increased intracranial pressure and how they're managed. For my own purposes, I've divided emergencies in the operating room into three categories. One is drug-induced, and that includes malignant hyperthermia, anaphylaxis, and hyperkalemic arrest. The second is patient-induced, and don't think that I'm suggesting the patient purposely induces a problem. This is the patient who has some kind of medical problem that leads to a problem within the operating room, and this includes things such as massive hemorrhage, brain swelling and increased intracranial pressure, and ischemic cardiac arrest. And then the third category I call doctor-induced or iatrogenic emergencies, which include wrong drug, wrong dose, wrong side, wrong surgery, and surgeon-induced hemorrhage. So we're going to start off talking about an extraordinarily rare condition, but one that has a very high mortality if it's not diagnosed early. And this is malignant hyperthermia. This is a genetic disorder that is transmitted in an autosomal dominant genetic fashion, but it's extremely rare. It occurs in less than 1 in a million people. The problem is that when it does occur, it's highly lethal, has an 80 to 90% mortality unless it's rapidly diagnosed and aggressively treated. When it is treated appropriately, it has a 90% cure rate. So the anesthesiologist who may go through a long career such as I have done and never see this disorder must be able to diagnose it instantly if it does occur. It's only seen either after a vapor is used on a patient or succinylcholine is used. But it is probably the only truly anesthesia-induced condition. It's a disorder of muscle calcium metabolism, very complex, but the bottom line is that large amounts of calcium are released into the muscle. Muscles go into spasm, muscle fibers are damaged and release myoglobin, which is the color in muscle, the material that gives muscle its orangish reddish color. This can lead to severe metabolic acidosis, renal failure, cerebral edema, pulmonary edema, and rapid death if treatment is not initiated. Temperature is one of the signs of this disorder, but it's a late sign. And nearly everybody believes nowadays that temperature is actually not a very good indicator of this problem, and that we have to be aware of the problem and be able to diagnose it long before temperature becomes an issue. The early signs of malignant hyperthermia are very nonspecific, unfortunately. They include tachycardia, rapid heart rate, without apparent cause, and a sudden increase in end-tidal carbon dioxide without apparent cause. These signs in themselves may be enough to make the diagnosis of malignant hyperthermia. The problem is that both of these things can occur in all kinds of other situations. The good news is if you start treatment and the patient doesn't have malignant hyperthermia, you really don't do any damage. So it's better to start treatment on the assumption that it may be malignant hyperthermia, further diagnose the situation, and if it turns out not to be malignant hyperthermia, you haven't done any damage. The only real drug of use in the treatment of malignant hyperthermia is a drug called dantrolene sodium. This has to be mixed, and it's difficult to mix, and the usual starting dose is 2 milligrams per kilo, which is about 7 amps. And it takes a team of people to mix this stuff, and you have to shake it for ages to actually get it into a state that will allow you to inject it. So you have to think about it early. You have to get a team of people working together really early on in this condition to reverse it and save the patient. Start off with 2 milligrams per kilo initially, then 1 to 2 milligrams per kilo every 3 to 5 minutes until the patient improves or you've hit 10 milligrams per kilo. If I ever see this condition, which I'm thankful I haven't yet, I'm going to carry on past 10 if I must. But hopefully, and the evidence from the literature would suggest, most people recover or start to show signs of recovery before you hit 10 milligrams per kilo. You should also start active cooling of the patient. Ice packs to the outside of the body, ice cold solutions lavage through the bladder and into the peritoneal cavity. ICU care is essential for these patients because the condition can reactivate later on. So you can get the patient under control, everything appears to be great, but unfortunately, several hours later, it may recur. So you have to have the patient in a monitored environment to make sure that you can treat them again if necessary. Very rare, but it must be diagnosed. This URL to the Malignant Hyperthermia Association of the U.S. has the best information on malignant hyperthermia you can find anywhere. It's all there. So if you're interested in this disorder and you want to know more about it, go on to that webpage, and all the information you'll ever need to know about MH is right there for you. The second disorder or emergency we're going to talk about is anaphylaxis, which is actually a fairly common problem. It's a major allergic reaction which is life-threatening, and it's nearly always induced by drugs, but it can be induced by things such as latex. Some people develop latex allergies that can be very dramatic. The clinical signs are usually the result of massive amounts of histamine being released into the circulation of the body, along with some other allergic mediators. It's usually characterized by the appearance of sudden and severe hypotension and tachycardia for no apparent reason. And those may be the only signs you have. So you have to, again, a bit like MH, you have to start thinking about what could be going on and start treating it early. It may be accompanied by bronchospasm, but it's not guaranteed. If the bronchospasm occurs, it may be very severe, so you have to be able to treat that. Patients may develop a rash that'll cover much of their body, and they may develop desaturation. The commonest cause of this during surgery is drug-induced allergic reaction, as I mentioned, and it's usually to antibiotics or muscle relaxants, most commonly succinylcholine. But increasingly, we're seeing it as a secondary result of the use of latex in people who have had repeated surgical procedures and have developed a sensitivity to latex. Rapid treatment with volume, in this case, IV solutions, and epinephrine, no other drug, epinephrine only, reverses the reaction. Initially, you give epinephrine in a dose of about 10 micrograms, and then you double it every 5 minutes up to a dose of 1 milligram. So it's actually a very large amount of epinephrine over a relatively short period of time. But if you're aggressive with it and you're giving volume and epinephrine, virtually all of these patients should respond. They may, however, end up with very large volumes of IV solution on board, which may lead to problems such as pulmonary edema or cerebral edema. They often look like the Pillsbury Doughboy. They're really swollen up, very obviously increased in size by the time they've recovered from the actual anesthetic, from the anaphylaxis. There's no point in giving antihistamines at any point during this reaction because every little molecule of histamine in the body has been released from the mast cells. There is some value in giving steroids, however, not because they'll have an effect immediately, but they will have an effect down the road. So they'll help with bronchospasm, with the anaphylactic reaction itself over the next 6 to 8 hours. These patients also require ICU treatment, even if they look completely normal, because full recovery can be followed within an hour or 2 hours with a recurrence of the condition that if the patients are not in the appropriate place, the condition could be fatal. Once you've made the diagnosis, you need to do allergy testing, get an immunologist involved or an allergy doctor involved, and determine what caused the problem. And then be prepared for the patient to come back for another anesthetic because they didn't get their surgery in the first place. I mean, you do not do surgery in the middle of an anaphylactic reaction. That's a major issue in terms of dealing with these patients with a recurrent surgery. So hyperkalemic cardiac arrest. Hyperkalemia is high potassium in the bloodstream. Normally, potassium is very narrowly controlled in our bloodstream. A lot of potassium inside our cells, but not a lot in the bloodstream itself. And the kidneys are responsible for excreting potassium, and our gut is responsible for absorbing potassium, and our body's homeostatic mechanisms are in place to control the level of potassium. But if potassium is given by the physician or through some error by a nurse in the ICU, or if you give succinylcholine to the wrong patient, you can have a very sudden increase in potassium. So normally a potassium, we'll say, runs around 4 milliequivalents per liter. If you give that patient, normal patient, succinylcholine, their potassium will go up to about 5 milliequivalents per liter, which is not a problem. If, however, you start at a higher level, for instance, in a patient with renal failure who hasn't been recently dialyzed, let's say it starts at 6, and you give them succinylcholine, it may go up to 7 or 8, and there'll be a cardiac arrest. In addition, if you give succinylcholine to people who have conditions such as neurologic problems, massive trauma, spinal cord injuries, recent burn in the last year actually, or renal failure, there can be a huge release of potassium into the bloodstream. And what happens with the ECG, and it happens over a minute or two, is the T waves, which are the last wave in the normal complex of the ECG, suddenly become peaked. And then the whole complex starts to widen. And then you can get what's called a sine wave, where it looks kind of like this. It looks like waves on the sea. And then asystole. And asystole is complete loss of contraction of the heart, complete loss of electrical activity in the heart. What happens with hyperkalemia is there's a change in the ratio between the resting potential and the threshold potential in the sinoatrial node, which controls our heart rate. This is a complex concept, and I'm not going to spend a lot of time on it because it really requires you to sit down and read in detail if you're interested. But what happens is that by changing the ratio of resting potential to threshold potential, the heart is unable to produce an electrical signal that'll cause an action potential and cause a wave through the heart. The only treatment for this that works quickly is to either lower the potassium, and unfortunately it's hard to do that quickly, or to give a drug that interacts with potassium to change that ratio of threshold to resting potential back towards normal. And the drug that you give is calcium. Calcium is never given in normal cardiac arrest situations because in ischemic cardiac arrest, it can actually cause cell death, and it no longer exists on the ACLS protocol. So this is an asystolic cardiac arrest where you don't use the ACLS protocol, you use calcium. This will very rapidly change that ratio, and amazingly, the normal heart rhythm will come back again. It doesn't, however, have any effect on the elevated potassium level in the blood. And you must treat that, and there are a number of ways of treating that, including hemodialysis, in which you actually take the potassium right off. You can give glucose or insulin intravenously, and that drives potassium back into the cells. Or if you've got a patient where it's not a huge problem, it's not that badly elevated, and you just want to bring it down over a couple of days, you can use an exchange resin such as K-exolate orally, and that'll help clear the potassium out of the system. So hyperkalemic cardiac arrest is, as I mentioned, it's an uncommon event, but I've seen it several times. It does not follow the ACLS guidelines, so you have to be aware of that. The treatment of the hyperkalemia is necessary even if the patients return to a normal heart rhythm. So you can't forget that. And I've seen one death because the physician involved sent a patient to the ward assuming that because the rhythm was back to normal, all was well. And the patient had a recurrence of the hyperkalemic cardiac arrest on the ward and unfortunately didn't survive.